Hi everyone, I want to talk about colorectal cancer screening. Colorectal cancer screening. Okay, let's go. The government is involved, and the next question you're going to ask yourself is, are you 50? So if you're 50, you're likely going to get a letter from your head region or the government of your province or state, as the case might be, in your mailbox, because they want to start screening, and that will involve Guaiac fecal occult blood test. It will be about that. gFOBT. Check your mailbox. You're likely going to get that. Okay, there are many things we can do to screen for colorectal carcinoma. We can use serum markers, not very useful for diagnosis, but if you have patients who will refuse standard colonoscopy, then you're going to try one of these. You can use SEPT9 or 7-gene biomarker test or carcinoembryonic antigen. Carcinoembryonic antigen is actually better for treatment monitoring and follow-up, not for diagnosis. Biliary enema is out of favor, so I'm not going to waste my time on that. You can have what you call CT colonography. That is possible every 5 years. If that is the option, that will require Bowel preparation with laxatives and glucagon for relaxation of the bowel. Another option is colon capsule endoscopy. In that case, that will be swallowed. It will be necessary if the endoscopy is incomplete. It's not a screening option. Bowel should be cleared before usage. The problem with capsule endoscopy is that it's a kind of camera that is going to view the entire gut once it is swallowed. But aside from translating or reviewing what the camera has picked, it cannot be used for biopsy and it cannot remove any polyps, but it will give a picture of what is along the tract there. Okay, sigmoidoscopy. So it means we are moving from capsule endoscopy now to sigmoidoscopy that could be done every 5 years. In this case, we need to empty the bowel with laxatives, and only the distal colon could be visualized. Here, we're going to use flexible fiber optic sigmoidoscope, and it's going to view from rectum to splenic flexure. You can visualize, take biopsy, or remove the polyps only on the left colon. The problem here is we can run into possible colon perforation, and if there's anything positive from sigmoidoscopy, colonoscopy will be required. It is more effective in men than women, probably because in women, they have right-sided lesions, and the lesions are at the proximal portion. Sigmoidoscopy done alongside fecal immunochemical test or Guaiac fecal occult blood test will be better option. Yes, this is what you are used to, colonoscopy. That is the most screening tool. I don't blame you. Someone will be saying, what is it talking about? They have spent 4 minutes listing all this. No, it is necessary because it's not everybody that will take colonoscopy, okay? Okay, you are now at, okay, you like this? Okay, let's go. This is the most screening tool. We use flexible fiber optic endoscope here as well. It seeks the rectum colon up to the ileum every 10 years, but it could be done in a shorter period if there's positive family history or there are polyps. You'll be required to stop anticoagulant or NSAIDs if you're on them, okay? And prepare the bowel before you embark on colonoscopy. It can remove or biopsy any lesion seen. Definitive as per colorectal cancer screening. Colonoscopy is definitive. Intestinal perforation is a possibility, just like we have in sigmoidoscopy. So that is the best option. Okay. In fact, if I will ask myself to choose, I'll first of all go for fecal chemical test, Guaiac fecal occult blood test, and if anything is positive, please just do colonoscopy. Why that? If you use capsule and if anything is positive, you're still coming to do colonoscopy. If you use endoscopy and it's positive, you're still going to do colonoscopy. And if you use serum markers, you're still going to come back to colonoscopy. So why not go for it from the onset? Okay, fecal immunochemical test. That measures immunoglobulin in the stool, either annually or every 2 years. Very easy and no dietary restrictions. If fecal immunochemical test is positive, then a colonoscopy should be called for. It is better than Guaiac fecal occult blood test. Well, with all due respect to the manufacturers of all these kits, I'm just presenting what is better for the patients. So I'm not for Guaiac fecal occult blood test or against fecal immunochemical test, but the truth must be said. Guaiac fecal occult blood test. Reagents are Hemoccult SENSA. That is the best. Again, I need to explain, I'm not selling anything for anybody, and I'm not spoiling the market for anyone. Okay? Just talking about what is best. Okay? Hemoccult II or Hemoccult R. No red meat for 3 days before testing. Okay? And you have to decrease vitamin C intake to less than 250 milligrams per day for 3 days before testing. In other words, what you want to drink, your orange, and so on. Anything that contains vitamin C and even multivitamins with vitamin C or vitamin C alone. Vitamin C can cause false negative results. Can't you see that is great? If you take vitamin C and you go for Guaiac fecal occult blood test and it's saying negative and colonoscopy is not done on time, and before you realize it, you do colonoscopy late, and of course, if disease has gone beyond repair, you understand what I'm about to talk about. Okay, let me skip that. You hold your non-steroidal anti-inflammatory drugs for 2 days before testing. No antacids or iron supplements. Okay, don't take sample while menstruating or when you are having hemorrhoidal bleeding or you are having hematuria. No sampling. Okay, the last will be multi-target stool DNA test with fecal immunochemical testing. That is fecal immunochemical test with DNA or colloid as it's called now, some localities. Basically testing for FIT and DNA mutations associated with colorectal neoplasia. That is done every 3 years. But the problem associated with this is you have to be very close to the center where that could actually be acid. Why? It must be treated within 72 hours of stool collection. So if you take the sample and you can't send it to the center on time, then it doesn't make any sense. With that, I've come to the end of possible screening methods as far as colorectal carcinoma is concerned. So consider your locality and what is available and get it done and get out of the problem on time. Thanks for listening. Kindly subscribe so that you can get these Presentations immediately they are published. Thank you.